Thank you for joining us today. I want to welcome everyone to this installment of the STS 2022 webinar series. This series features presentations and panel discussions on a variety of topics relevant and important to cardiothoracic surgeons. The topic today is the changing face of pre-treatment nodal staging for patients with lung cancer and is sponsored by AstraZeneca. Please note, this webinar is being recorded and will be available on the STS website and YouTube channel. We invite you to become a member of STS and you'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership. At this time, I am pleased to welcome our moderators, Dr. Farhood Farjah and Janet Edwards. Dr. Farjah, welcome, and I will now turn it over to you.
Thanks everybody for joining us this evening. We're excited for a vigorous discussion tonight about pre-treatment nodal staging for lung cancer. I'm Janet Edwards. I'm a thoracic surgeon in Calgary. And just to let everybody know, we were hoping to have Catherine Sears from Indiana University here with us tonight, but unfortunately she has laryngitis, so we will power on without her, and I'll hand it over to Farhood.
Hi there. Thank you for joining us this evening. My name is Farhood Farjah. I work at the University of Washington in Seattle in the Fred Hutchinson Cancer Center, and I'm co-moderating with Dr. Edwards, and I don't have any disclosures. Dr. Evans?
Hi, my name is Nate Evans. I am a thoracic surgeon at Jefferson, Philadelphia, and I don't have any disclosures.
And Gonzalez, I'm the lone non-surgeon in the group. I'm an interventional pulmonologist based at McGill University in Montreal, Canada.
Moishe Liberman, also from Montreal, University of Montreal. I'm a thoracic surgeon. I have no relevant disclosures, and I have a big interest in pre-treatment nodal staging in lung cancer.
Well, one disclosure, Dr. Edwards and I were very intentional of balancing the United States, Canada, pulmonary, and thoracic surgery. So I'm sorry, Dr. Gonzalez, it did not work out that way. On behalf of the STS and Dr. Edwards and myself, I just want to thank the panelists. The fundamental reason we're having this webinar on the changing face of nodal staging is because of the changing face of lung cancer treatment. Historically, the role of pre-treatment nodal staging was to diagnose and stage patients who were eligible and willing to undergo curative intent treatment. And curative intent treatment has historically consisted of surgery or radiation for local only disease, or multimodality therapy with combinations of surgery, radiation, and chemotherapy. But there's been this explosion of enthusiasm about targeted therapy and immunotherapy in patients with stage 4 lung cancer. And it's naturally inspired trials looking at targeted immunotherapy in the perioperative setting. Recent trials such as ADAURA and Checkmate 816 have shown effects of targeted and immunotherapy in the perioperative setting in terms of an intermediate term patient outcomes. So because of these and other ongoing trials, the pivot with pretreatment nodal staging is a change in focus from just diagnosis and staging to diagnosis, staging, and acquisition of sufficient tissue for comprehensive biomarker testing. And this pivot not only requires a focus on the procedural elements of staging, but also on the workflows that integrate all the information that comes from the procedures, the biomarker testing into our treatment decisions. So we're here to learn from our expert panelists on how pre-treatment nodal staging may evolve. in response to advances in therapy for patients with resectable lung cancer. So again, thank you to all the panelists for sharing your thoughts with us. And for the audience, we want to encourage you to put in any questions and answers. We have several questions for our panelists, and we would really love to take on additional questions that any participating audience members have.
Excellent. So maybe I'll lead off with the first question to the panel. So prior to the release of ADAURA and Checkmate 816, how did your institution approach pretreatment nodal staging in terms of patient selection, procedure or procedures of choice, the ideal extent of pretreatment nodal sampling, and the treatment regimens applied to patients with N1 disease, single station non-bulky N2 disease, and multi-station non-bulky N2 disease? Maybe we'll start with Dr. Evans first.
Sure, thank you very much. Yeah, I mean, I think we were pretty aggressive about mediastinal staging even before that, but it was certainly pragmatic in that it was, you know, we would stage people if we thought it was going to change their treatment plan, right? So certainly anyone we were concerned about N2 disease would get some sort of invasive staging. Our general approach was to start with EBUS and then go to mediastinoscopy if there was some concern after EBUS. We generally, you know, we do a lot less mediastinoscopy now than we used to, I think, like everybody else does. In terms of, I'm trying to think of sort of a three-part question there. The other part of your question was about how do we approach people like stage 2 disease and non-bulky N2 disease. I mean, we generally approach them with some sort of preoperative, well, certainly for stage 2 disease, we generally operate on people. We weren't necessarily giving induction therapy unless they were on trial. We had a couple trials here that we were running. So when they were on trial, we would give them, you know, we had a very similar trial to Checkmate that we ran as a phase 2, and then, but off study, we would just operate on them. And then for 3A disease, we were doing a lot of chemotherapy and radiation, you know, full dose radiation followed by surgery. And of course, those patients need to be staged pre-op to confirm that really need that. So I don't know if I answered your question, but that was our approach.
No, that was great. Thank you. Maybe we'll move on to Dr. Gonzalez.
Sorry for the delayed unmuting. Yeah, I mean, I think the approach to patient selection was as described. I didn't report any disclosures. I'll disclose that I was one of the authors on the ACCP3 staging guidelines. So certainly I'd like to think that we, you know, would follow those, and as well as the European guidelines in terms of who to pursue a nodal staging in, whether it's a central tumor, a tumor greater than 3 centimeters, which is more the European guidelines, or evidence of N1 disease. One challenge we've had locally in the past was timely access to PET, which meant sometimes we would be doing mediastinal staging based on a CT without having a PET available, and with, in fact, improvement in our workflows for the patients in whom there's really a question of N2, N3 nodes, or to know whether there's mediastinal mets that should be targeted before we go to nodal staging. We've been able now to get PET scans in a more timely manner. So that's very helpful in terms of having that to guide the mediastinal staging. I would say that's been one of the big improvements, and then to try to have that subsequent multidisciplinary discussion for patient selection, which with that information available, which we do at Tumor Board on a weekly basis.
Dr. Liberman?
Yeah, thanks. I agree with what Anne and Nate said. You know, we were a big recruiter in Checkmate, so we did a lot of the nodal staging for that study. I would say that at our institution, we're big stagers. You know, I think we're known for that. We've been staging people for years here with not only mediastinoscopy, but with EBUS in the US, and we typically sample 4 or 5 nodal stations on a regular basis. So we haven't really changed all that much. I would say what we have changed since neoadjuvant, especially in the immuno setting, is we're doing more N1 staging than we did before. I would say that in the low risk patient, I'm saying a low surgical risk patient with N1 disease on PET and CT. We used to do N2, N3 staging and then operate on them. I would say over the last 5 years, we've been staging N1 and all of those patients when the N2 and N3 are negative. And my bias is to give them induction, even with standard chemo pre-op, because I know I'm going to give it to them anyways post-op. And I think we all know that a lot of patients never make it to their adjuvant chemo because of physical status post-op or a surgical complication or just, not able to tolerate pre-op. They almost all can get it. Now we're doing that with immuno, but I'd say 5, maybe even 6 years, we've been staging N1 and treating patients up front if they agree to it, knowing that they're going to get it post-op regardless of if their N2 and N3 is negative. I think that's what changed the most for us. Also, when I started my practice doing a lot of staging, we just needed positive or negative. I think that we're all in that situation where, we don't do MEADS anymore, very few MEADS, and EBUS isn't any more positive or negative. You need all of your molecular. I think it's super important, especially if you're talking about inducing for EGFR or for KRAS or any targeted mutation. So we're now not only staging a ton of nodes, but big staging of nodes. So we want to have big worms, lots of tissue. We don't anymore use small needles. We're not happy anymore with a result of positive or negative for cancer. I think that's where the world is going. In our practice, mediastinoscopy, we're 7 thoracic surgeons who do about 1,000 major resections a year. We maybe do 1 or 2 mediastinoscopies a year. Almost always it's for like a patient who had 3 EBUS, EUS for lymphoma, and we still can't subtype it, not because we didn't get it. I can't remember the last mediastinoscopy I did. And I think that's where the world is going. So I don't know if I answered your question, but yeah, bigger, better, more. We're surgeons. We're going to do a lot.
Excellent. Yeah, I admire the 4 to 5 stations because here I find we don't all do our own staging EBUS. And sometimes if you send to someone else to do it, we might get an 11 sampled and nothing else. So
7 is the classic, the 7.
Yes. Excellent. Well, hand it over to Farhood for the next one.
Yeah, well, Dr. Liberman, I appreciated the reference to worms. I actually did an EBUS today, and I've been calling it snakes up until today. And then our fellow, Dr. Clark, brought up worms. So I'm glad there's many options for the nice cord.
I use worms because in French, worm is ver, and it's very easy. The nurses and I know that. I don't know what the French term, maybe Anne knows, for it's serpent or something. It's very complex, so we like to keep it
worm
simple.
is ver, but we call them spaghetti, so we're happy when we say spaghetti, so that goes to show.
Not all of those worms are tissue. A lot of them are
those
blood
are blood,
clots,
exactly. I think it's a
but,
false.
if you have a good slide and a lot of those worms, usually you're okay, but not always. Yeah.
Well, one follow-up question on Dr. Edwards before, because I was going to ask you about the new treatment and the adoption of new treatment, but I'm really curious about your institutional approach to stage 3A disease, and maybe more specifically, 3A defined by N2, recognizing that 3A is a very heterogeneous group in and of itself, and the practice patterns across the nation are very different. Some folks do not consider 3A a surgical disease, and many folks do. So I'm curious because this we may come back to how the new therapies might be changing institutional approaches to 3A, but it all starts with what were you doing before the trials? Were you not including surgery, or were you only doing it for single station, non-bulky, or were you doing it for multi-station? So maybe we could start with Dr. Evans, and how are you guys generally approaching 3A, given it's a very heterogeneous group?
Sure. Thank you. This is like a pet project of mine. I'm very excited about like managing 3A. In fact, I'm going to use this as a plug November 10th, we're going to have another webinar, 7 p.m. same time, STS webinar on management of 3A disease. It'll be me and Rob Merritt. And actually on that panel will be our Chief of Radiation Oncology, Maria Werner-Wasik from here, which brings me around to kind of how we manage 3A disease. I think we've been very aggressive about sort of tri-modality therapy for 3A disease. So, our approach to 3A is basically you need to prove that they're not surgical in some way before you decide they're not. So I'm not a big believer, and I think our group isn't a big believer in the distinction between like single station and multi-station 3A disease. It's been more of, do we think it's resectable or not? And I think before we were involved in the immunotherapy trials, we were giving everyone chemotherapy and radiation. We enrolled in that RTOG trial that looked at a couple of RTOG trials that looked at high dose radiation with chemotherapy for 3A disease, and that was pretty much our standard up until Checkmate. I would say now we generally will consider people for sort of a Checkmate type regimen for 3A disease. I think if their PD-L1 is really low, then there's some debate. And the other debate that we have, and I'd be curious about how other people are managing this, is for superior sulcus tumors. And what do you do with that person who comes, like we had someone tumor board this week who has superior sulcus tumor. Now, fortunately, it was kind of easy because their PD-L1 was like less than 1%. So we just went with sort of the standard chemo radiation and then potentially surgery pathway. But I think that those are the times that, and when people have, EGFR mutations, are the time that we are still not quite sure what to do.
Dr. Gonzalez?
Yeah, I want to say for 3A disease, obviously, and I'm not a surgeon, so those are the cases where if I think the patient has, obviously we'll stage them very thoroughly prior to having the discussion and have the PET and have an EBUS with sampling of N3 nodes and review them either in our joint tumor board or in our multidisciplinary lung cancer clinic, where the patients have the opportunity to meet both a thoracic surgeon and a radiation oncologist and an oncologist. I have a sense that when 3As were being operated locally, there wasn't a lot of radiation being done, I want to say, and probably more selective. And there's been some healthy discussions between our radiation oncologists and our surgeons at tumor board on select cases. And yeah, I think probably somewhere in the middle, that yes, they were being operated. It might depend who they were initially seen by, I suspect, and probably more selection in terms of being single station. And then more stations involved for N2 disease. But yeah, generally on a case-by-case basis, they would be discussed.
Dr. Liberman, how about at your institution?
Yeah, I think sort of more, I would say in the middle of the two other panelists, I would say that we are very aggressive at surgical treatment of N2 disease. We don't operate N3 disease in general. I think that's similar to the other two institutions. I'm not against chemo radiation as a definitive treatment. I really think it depends not only on, I think I agree with Nate that it has to be resectable. So we're not going to operate people that we're going to be leaving disease. But the thing that's more important, because we can take almost anything out. I know Nate can because I've operated with him many, many times. But I don't think removing stuff is hard. The hard part is finding a patient that can tolerate neoadjuvant and surgery. And so if I'm worried about a patient's age, their comorbidities, their lung function, their physical status, I have no problem sending that patient for definitive chemo rads. If I feel they're operable, we can remove it and they can make it through the treatment. I agree. I like chemo, immuno, pre-op. We're not big believers in radiation. I know Nate and I agree on almost everything except on this point. We've moved away from induction radiation, except for in the superior sulcus. As Nate said, we're still doing that. I think that the ideal treatment, at least in our setting, for superior sulcus would be neoadjuvant, like a SWOG protocol plus immuno. And obviously, like Nate said, if you have a very low PD-L1 or if you have a EGFR mutation, we obviously will be using targeted therapy specific to the patient's tumor if it's available. Yeah, so I think that's where we are. I think most centers are still using radiation for superior sulcus. I don't think immuno alone is enough because really it's a margin issue, and that's why the radiation is so important. I think we shouldn't leave that out. For lobectomies, sleeves, and even pneumonectomies, we've moved away from radiation just because of the morbidity, and we didn't see a huge survival advantage. Again, there's many ways to skin a cat. I'm not saying our way is the right way. And in terms of, you know, who gets the patient, radiation or surgery, it's a hard decision in some centers, but not in ours because we control the patient flow. So we see the patient, we stage the patient, we treat the patient, we talk to the patient, and we decide whether they're going to be, I mean, obviously the patient is involved too, but radiation oncology is not a doorway into our hospital. So they can only get a patient if it was sent by one of us. So we don't have that sort of fight where they're fighting over the patient because they don't know about the patient. Not that we're hiding it, but how would they know?
I'm curious, my last superior sulcus was a large cell neuroendocrine, and based on that pathology, ONC decided not to do radiation. They said, oh, they're so chemosensitive. And then even going wide of the tumor on the bone, there ended up being marrow involvement, and I'm not sure that that was the right decision. So I'm curious if you've run into that. Anybody else?
I've seen similar cases. I always give, I mean, I don't do it myself, but I won't operate a superior sulcus or a vertebral column with canal invasion without radiation.
Yeah, I don't think I'll do it again.
And I'll still try and get a negative margin, but you're talking about millimeters of margin. It's not like a lobectomy.
Okay. Moving on for our next question, maybe we'll start with Dr. Gonzalez this time. Has your institution adopted adjuvant osimertinib for patients with resected lung cancer and an EGFR mutation? And have you adopted neoadjuvant chemoimmunotherapy for patients with resectable lung cancer? And if so, who is receiving those regimens?
Yeah, so for the osimertinib following the ADAURA trial, we are. I feel like I'm in charge of our rapid investigation clinic, and so I do that on a weekly basis, and the diagnosis and staging. And so I see my role as really preparing a patient, and so that there can be the best possible treatment decision made by a team. And so, in fact, I don't see all my patients post-operatively. We have established reflex testing so that, except for the very, very early stage adenocarcinomas, T1A, or even see if there are subsolid lesions being resected, very small, minimally invasive testing won't be done unless it's specifically requested, where maybe a patient had multiple lesions in their lung. There's a question that really warrants having a molecular analysis, but other than that, the analyses are being done. But I feel it's really the surgeon post-operatively that's seeing the patient with that pathology result, and so we would then be referring back to oncology for treatment. And then, Dr. Spicer at my institution was also involved with Checkmate, and there was significant recruitment at McGill for that trial, and so there is a program now for access to adjuvant nivo and chemo. So those patients are being referred when they would meet criteria in terms of resectability and performance status, of course, to go through that. Dr. Liberman?
Yeah, I mean, I work in the same city as Anne, so we have access to nivo chemo on a neoadjuvant basis until the government pays for it. The company is giving it to us on compassionate basis, and it's pretty easy to get. We're getting it all the time. Osimertinib, we have access to it in the adjuvant setting, but we use it in the neoadjuvant setting. We just don't tell anyone. So I hope we're not recording this. when we need to. When we need to for the right patient, we will use it. I did 2 cases in the last 3 weeks, but it's not yet approved. So we need to sort of give it as palliative treatment and then switch them to surgical. But it'll come, and we're going to be giving it on label soon enough. At the end of the day, we do what's best for the patient. And I think that if we can get access and we're able to, then that's better for the patient. I can't imagine in 2-3 years that we won't be giving neoadjuvant to any patient who has stage 2 and above. Stage 3 is just the tip of the iceberg, because all of those patients benefit from adjuvant, and they, in my opinion, benefit from neoadjuvant a lot more. It also makes more sense to me to give systemic therapy before you cut all the lymphatic and vascular supply to the lymph nodes and the lung. Why would you not give it in a patient who has all of their normal anatomy and sort of highways to the tumor and lymph nodes available before you operate on them?
Dr. Evans?
I like that, highways to the tumor. That's a good one, Moishe. I'm going to steal that one. Yeah, so I think very similarly, like, as I was saying, we were pretty heavy into preoperative chemo radiation. We really have switched completely after Checkmate. I mean, almost, any patient I totally agree with Moish in that, like, any patient who would get adjuvant chemotherapy, 5 years ago, are the people that we are offering neoadjuvant chemoimmunotherapy. And at least in our practice, that's really driven by the surgeon, right? I mean, like, they come to us for an operation and we tell them, actually, you'd be better off if you were to get additional therapy first. And so that we've certainly everyone in our practice has sort of transitioned to that. In terms of adjuvant osimertinib, I would say we certainly do it. I think that the appetite to do it gets stronger as you get higher stage disease, right? I mean, the 1B patient who, or I guess now the stage 2 patient who's resected, with a EGFR mutation, I think the oncologists don't push too hard for adjuvant OSI. I think certainly for the sort of, the bigger tumors, the N1 nodes, the unexpected N2 nodes, those, I think they're much more aggressive. But yes, we are doing it.
Okay. So just to get a sense, is anybody sending 1Bs for consideration of neoadjuvant or no? You are?
No, I'm not.
So I guess it depends on what you mean by 1B. So if you mean by the current staging, so anyone over 4 centimeters, I'll send them at least to talk to an oncologist, especially, I mean, I guess we'll get to this a little bit later on, especially if they have a high PD-L1 from their biopsy, right? I mean, which is an interesting problem because previously those patients might not even had a biopsy. If you had a 4 centimeter tumor that was clearly a cancer and you get an EBUS, and if the nodes are negative, you get a resection. But I think, I think we're more aggressive about making sure we have tumor tissue and know what their molecular status is now, because I think there's a good argument to be made to give them neoadjuvant.
Okay. And Dr. Liberman, you had a different practice?
Yeah, no, I think I agree somewhat. Like we definitely are offering it in the N1 positive. I'm not talking about positive on PET or CT, on true EBUS positive N1, we're offering it. For the size of the tumor, in a very young patient, I agree, I will do it. On a peripheral tumor at 4.2 centimeters in a patient who was staged by us that I know is N1 negative, we often will operate up front and then consider potential adjuvant based on what the tumor was. We don't often biopsy those tumors, but I'm not against it. Meaning, and I think it's evolving. I think I might change my opinion over time, especially as we see some of the safety data coming around from not only Checkmate, but from Keynote, maybe to give neoadjuvant to those patients. But, I've had patients die also from neoadjuvant before they got to surgery. It happens, you get immunolung problem, they don't get operated. So I worry about those people, especially when they're N negative, knowing that in the adjuvant chemo trials for N0 patients, the benefit was very, very low for adjuvant chemo. I'm not saying that immuno is the same. I think it's better, but most of those patients, like T1 and 0 are alive at 5 years. So I just don't want to hurt them. Again, I don't think I have the true answer, but I'm a bit hesitant to give a neoadjuvant in negative disease.
Yeah, I find of the 1Bs I would send over, it's less than half that seem to end up on the drug. Dr. Evans, do you find that different at your center?
I mean, I think, I guess the ones that we send over, I feel like they're pretty commonly get the drug, but I think that's partly because, when they come from us and we've told them we think you should get a drug, they're sort of already go to the oncologist. It's like when someone shows up in your office and they've been told they need an operation, right? Like it's much easier to then convince them they should have an operation, So I think especially because I think partly because we had a trial even before Checkmate that we were running that was had a very similar protocol, and we enrolled sort of that protocol. We wanted to enroll people, so we were enrolling forced immunotumors, and I think that sort of that became sort of the culture here. So I think it makes it easier.
Thank you.
So we spent about half the time talking about treatment, but that was intentional. It was intentional to set the stage really for the question about changes in nodal staging, and some of it's already come out in what you've shared. We've heard about reflexive testing. We've heard about looking at how N1 was treated with surgery first at an institution, and perhaps there's a change. So can you give us some specific examples of how your nodal staging strategy has changed in light of these new treatment regimens, in terms of whether it's the indications or how many nodes you go after, how the biomarker testing is done, who orders it, anything concrete that you could share with us, because I think all of us are wrestling with these questions of how do we redesign that pre-treatment space in light of some of the new considerations that we have to take on with the biomarker testing. Dr. Liberman, do you want to start?
Sure. Yeah, well, I think I follow Anne's guidelines, I have to say, and I teach them to my fellows. I think they're spot on. I think we should use them. The only caveat is once in a while in a very high-risk patient, I will stage them if they don't meet criteria, just because I would hate to find out I was wrong. And those patients, the very high-risk surgical patient, I'll sometimes stage. But if not, I think those guidelines are awesome, and we should everyone should follow them. I will say that I think I mentioned before, but I've changed the way I stage in terms of the volume of tissue I want to get, and also going after N1 nodes. 6-7 years ago, I never went after N1 nodes unless I needed tissue for a patient who was not going to be operated. Let's say, they had an N1 node and they were pulmonary cripple, or they had a previous surgery and we thought it might be a recurrence or something like that. But in the old days, if you had like a 3-centimeter right upper lobe tumor and your mediastinum was negative, well, I'll make it easier. You have a 6-centimeter right upper lobe tumor and your mediastinum is negative on CT and PET, I would do an EBIS and sample 2R, 4R, 7, 4L, and then I would be done. And if they were negative, I would do a right upper lobectomy with hilar and mediastinal lymph node dissection. And if they were N1 positive, I would say great, and I'd send them for adjuvant chemo post-op. Whereas nowadays, I'm always going after the N1 because I believe in induction for N1 disease. So that's sort of how the way I've changed the way I stage patients. In terms of, what was the other question?
It's about the workflow. I mean, are you like who's doing the biomarker testing? I mean, we talked about chemo immuno, but some institutions are, for instance, doing comprehensive biomarker testing, because if they know there's an EGFR mutation, they're not going to give the chemo immuno. They're going to give the OC afterwards. So those kind of workflow issues, how are they incorporated in the staging?
So it's a good question. So if we have nodal disease that's positive, it's reflex testing. If it's just tumor itself and it's early stage, let's say for transthoracic needle or a lobectomy or wedge or whatever, then the patients don't get reflex testing, but we can get it if we ask for it. We just don't do it routinely because we might only need it never or in 4 or 5 years if they recur, and it's expensive, and we're working in a socialized healthcare system with a lot of constraints and strains in terms of cost. Yeah, I mean, they're quite slow. I find that it's just because the labs are super busy and the tests themselves take time. So, there's in Canada, I don't know how it is in the US, but everything takes time. It takes time to get your appointment, to get your PET, and to get your EBUS, and then to get your molecular, and then to get your surgery. So those just add time. But I think the tests are getting better and they're getting faster, and eventually they'll be done by, using less human time. Yeah, so I think that's the answer for us. I think probably similar at McGill, Anne, where you guys are doing like reflex on the higher stage and PRN on the lower stage.
Yeah, that's exactly what's happening. I feel like I've kept my habits that preceded reflex testing. I'll write on my requisition, please do molecular testing whenever it's obviously metastatic disease, but even like higher nodal disease. But yeah, probably even if it's just N1, I'd have to write it, but it is getting done now for nodal disease, and if requested on the primary tumor, and post-operatively, except on a very, very small tumor, it's being done as well. And at our institution, there's no question that both reflex testing and also at one point, certain tests were being done at another hospital, and they've become more centralized, and that's helped enormously with our delays. So both, yeah, the reflex and centralizing or bringing back some of the testing has helped. I must say that, we've had good success with PD-L1 testing on our nodal samples. I tend to use, I have colleagues who like the 21 gauge. I've used the 22 gauge. I use a 19 gauge needle for EBUS on very select occasions. And so in fact, we've not had issues. We know PD-L1 is highly feasible on EBUS samples, and the same for EGFR and other molecular testing. So I might take additional passes, but I don't necessarily reach out for a bigger needle. I usually do take additional passes from the node that I think is the most likely to yield tumor cells. But yeah, it hasn't changed my practice in terms of needle gauge.
And Dr. Evans?
Yeah, I mean, in terms of changes, I would say similar. We are, I think, more aggressive about going after N1 nodes than we used to be, because it actually makes a difference. And I think also being cognizant about making sure we have enough tissue for PD-L1 and molecular testing. Those are probably the two biggest changes. We're lucky here in that we pretty much do reflex testing on any lung cancer specimen that comes out. The exception being like if it's a brain tumor, they might, we have a big neuroscience hospital, and they sometimes forget that not everything that comes from the brain is not from the brain. So, but any true, once they recognize that it's a lung cancer, then we reflexively do PD-L1 and molecular testing, and so we're kind of lucky that way.
Okay. We're getting audience questions. I think people are really curious about when do you operate after the neoadjuvant immunotherapy, and I think a follow-on would be: are you finding it more difficult? Is there certain challenges that you've noticed?
Maybe I just want to answer, because maybe I made myself unclear before, just to clarify. I don't use 19 either, for 19 gauge needle either. When I say bigger, I mean I'm taking a lot more specimen, like Anne said. So 19 is very expensive. I don't think it's any more risk, just costs double, and we don't spend the money unless we need it for lymphoma or sarcoid, and even then we don't always. We use 21. I think 22 is fine. I just prefer 21, but we're not using 19 routinely. And I'll just maybe answer your question. We usually operate between 4 and 6 weeks after neoadjuvant, immuno or chemo. I'll say that for the osimertinib patients, I've been continuing to get through surgery. So we don't stop it at all. We give it even the day before. Usually we don't give it the day of. I don't know why, but we could. I mean, if you give it the day before, and we give it the next day, I haven't had a problem, especially in the patients that have excellent responses on osimertinib. I think you should not stop it. In terms of the risks of surgery, these are hard cases to begin with, okay? The N2 patients, even without induction, are difficult to operate on. Induction makes it much, much harder. Surgery after neoadjuvant immuno in an N1 or N1 is hard, but in an N0 patient for a large tumor, it probably doesn't make that much of a difference. But when N2 or N1 are involved and you're having to do complex surgery, it's really hard. I think the robot really helps in those cases. It's much more precise and easier to dissect out those nodes. You have to accept a higher, at least in my hands, you have to accept a higher conversion rate and be okay with that and not be scared to convert. I think you can do most of these cases minimally invasively, but I think your tolerance for conversion should be lower. And I tell the patients pre-op when I consent them that when I consent a patient for a VATS or robotic lobe, I tell them it's a 1% conversion rate. And then when I consent them for a neoadjuvant lobe or sleeve or whatever, I tell them it's a 50% conversion rate. I think that's probably high, but at least they're well prepared if it happens. They're tough cases, there's no question. And the immuno cases are even harder. It's better for the patient, but harder for us. And I think that as surgeons, we have to be a lot better than we used to be. Surgery is much more difficult today than it was 5 years ago, but you can do a wedge for small peripheral tumors without doing lobectomy. So it's easier for you there because we saw at World Lung a few weeks ago that's acceptable and equivalent. So your life is harder in some places and easier in others.
I love the honesty that you speak, because I think a lot of people try and sell you that it's the same operation, and so it's
there's
nice
no way. I have about 100 videos for you. There is no way it's the same operation.
Okay.
And some of them are all red, like in a very wet video. Very scary.
See, now I believe you. I believe you. Dr. Evans?
Yeah, I totally agree with everything Dr. Liberman said. I think Sam, I lost my train of thought because he said all red and I got like chest pain for a second. No,
by the way, Nate and I used to operate together as
well. When I visited you as a fellow, he was proctoring you on the robot.
Oh, there you go.
Yeah.
Nate taught me all my bad moves.
I told him all those red maneuvers. Yeah,
he's much older than me, much older.
Yeah, so I totally agree with Moishe that these are hard cases. I think especially when they have nodal disease, right? If it works, then the nodes like explode and they're like plastered to everything, and I think it's very challenging as some of the radiation cases that we did as well. I find it a little bit more variable than the radiation cases. I would say there are a couple cases where I've been surprised by how not terrible the immuno cases are, but in general, if they have positive nodes and they get immunotherapy and it works, it's a hard case. I will say the one thing I'll say about that though is in the rare instance where you need to do something like a sleeve or a pneumonectomy, I'm much happier doing that after chemotherapy and immunotherapy than I was doing it after chemotherapy and radiation. And I think the patients are much happier. I think their risk of having postoperative complications is less, I think. So I think that's another sort of reason why we at least are certainly swung more in the direction of chemoimmunotherapy for 3A disease. I don't know if I answered the question that you asked, but
no, you totally did. Yeah, thank you. Dr. Gonzalez, did you want to weigh in at all?
Oh, I don't think I can, but I'm learning a lot.
I felt rude not to ask you.
No, that's okay.
Farhood?
So there's a question from an audience member, and it's asking more about the reflexive biomarker testing, and I think a little bit more detail about that in terms of reflexive, meaning it's happening automatically, but whatever automated process, is it literally everybody, or is it everybody 1B and higher? And then this question comes up of like, where do the results go if you're using NGS, is it all the results in a big PDF, or is it just the EGFR and the PDL1? And so maybe some more details about your comprehensive biomarker testing. Dr. Evans, you want to start?
Sure. Yeah. I mean, this has been kind of a long journey for us, so I can tell you sort of how we got to this point. And it's a continuing journey because, now we're, when I started here, we had like 2 hospitals. Now we're like a 14 hospital health system. So the question now becomes, are we doing the same thing in all these at every, person who has lung cancer diagnosed within Jefferson Health? And we're getting there. The question, I saw the question, and, for us, it really, the central part of it was getting to pathology and getting a champion in pathology. We're lucky, and that our chairman of pathology has a significant interest in molecular pathology, and especially in lung molecular pathology. So so they were more than willing to sort of partner with us. And there is some logistics around. Really, we really came down to us as the lung cancer group, formally sending a letter to the pathologist saying, hey, we would like you to do X, Y, or Z, because that then allows them to say to, the hospital or whoever that, like, this was the request that we had, so that every lung cancer patient will get this done. Now, as Dr. Liberman pointed out, it's expensive. They can't bill for some of them, especially if depending on the timing when they do it, when they're in the hospital. There's, so there are certainly ways around that by doing things like batching results and not necessarily having to have them, immediately, but we are usually getting them within a week or two. And then the other question you asked about, what do the results look like? So they're running a pretty, I would say, aggressive NGS panel on our lung specimens now. And if they were to send me all those results, I wouldn't know what to do with them. And it would just slow down my clinic, me trying to read through and find the important stuff. So they're kind enough to, we've kind of pointed out to them the things that are interesting to us, and they will sort of point out those things and send a report that just has those things in it. And in fact, the report says, like, these are the things they have, and these are the, relevant, studies that have to do with those mutations, which, we can then, adjust over time as those things change. But, it is nice because then they have all the other data sort of in the background when we go back and have research questions or have, or something changes about what's useful. But I would say that it really comes down to having a pathology partner that's invested, because I do think it's much easier to do it that way. That there's other ways to do it with some outside system that I think if you're having to send stuff out, it gets much more challenging, especially if you want to try to do it reflexively. So for us, it was really just about getting the pathology and telling them we'd like you to do everything, and they were willing to do it.
Dr. Gonzalez.
Yeah, no, I mean, I guess we're lucky. This was one of the issues that as a cancer network, we were able to really work on and improve. So we have an NGS panel, and, PDL1 gets done in a timely manner as well, with the reflex testing that we already discussed. We had, big issues before, and when testing was being done off-site, and patients might be planned for chemo, waiting for a chemo chair. The results were still pending, and maybe start treatment, and the results of biomarker testing would arrive after. So really, those types of events really prompted us to alter that process, and so it has improved the situation. It's not perfect, but it's much better than it was.
And is it selective reporting from the NGS, or is it like the whole?
It's a whole 3-page report that comes, but that will really highlight if there is something of note, and now with references. And you're right, there's the common things and things where there's a mutation that I need to learn about, and I'm glad the oncologist is going to deal with it, but there'll be references. Like it's a helpful report, but it is a long report. Yeah, and one that I suspect will keep evolving over time.
And Dr. Liberman?
Yeah, similar to Anne, we don't do NGS reflex here. We can get it. We ask for it when we need it. EGFR, ALK, KRAS is pretty, and PDL1, pretty routine for anything above stage 1. But for NGS, we need to ask for it, and then we can get it. I guess that may change with time, but we're not getting it routinely yet. And when we get it, it's the same as Anne described, that long report that very hard to understand, with a lot of things that we have no actionable treatment for anyway. So let's all not get excited about NGS if we don't have any drugs that can target those mutations.
We're getting a question about N3 disease. So now that it seems like there's more operations being done on the N2s, do you find that you're more deliberate about making sure there's N3 sampling, as that seems to be more of a stopping factor?
Is the question, do we operate on N3 or do we stage N3?
No, I think they're asking, are you more intentional about making sure you sample N3 nodes, given that you're likely not to operate on those, but the N2s you are?
Yeah, I think you should be deliberate about N3 regardless. I don't think it has anything to do with this. Meaning, if you're staging a patient, the most important node is the N3 node. You know, N2 is second, then N1, but you should be staging N3. When we used to do mediastinoscopy, which was the gold standard for many years, and I'm the first one to tell you it's not, we did a minimum of 4R, 4L, and 7 in every single patient. You have to do the minimal of that in every single patient. Plus everything else that you can do now with EBIS in the US, N1, 2s, 5, 6, adrenals, liver, whatever, but N3 is vital. And you don't want to operate a patient who you think is N2 and find out 3 months later that the contralateral node lights up on PET. Because, you know, it's a high risk thing to begin with. You know, a lot of the patients don't benefit from induction and surgery. You definitely don't want to be doing that on patients who have higher stage disease than you think.
Dr. Gonzalez?
Yeah, I agree with what Moishe said about N3. One thing I was happy about was when David Ost published his paper looking at the prevalence of contralateral hilar mets, because I do, the vast majority of our EBIS is done under conscious sedation. We don't have ready access to anesthesia, and so sometimes time is of the essence to do complete staging. And so and we really try in potential surgical patients to have the PET scan ahead of the EBIS. Let's book the EBIS right after the PET. And yeah, if there's no suspicious N3 nodes on the PET and the hilar nodes are small on EBIS, at least I know I can skip those and concentrate on the mediastinal N3s. So that's been helpful. And then, yeah, as much as possible, we do try to do the 4R, 4L7. Sometimes it's hard when they're really small. When you really have like a 3 millimeter, are you really going to go after that? And so, in fact, we took part in the Canadian lymph node maps study. We're waiting for the results, but I think eventually we might become more selective in terms of what we sample by EBIS, if they're PET negative, EBIS negative in terms of criteria, and CT negative. But right now we do try to sample the mediastinal N3s definitely.
Dr. Evans?
Yeah, I agree. I mean, I think I don't, the question was whether or not we are more aggressive about staging in 3. I mean, I agree with Moishe that I think, you know, that's the most important one. If you're going to stage mediastinum, like that's kind of the only one that, essentially the only one that matters, but it's, you know, by orders of magnitude, the most important. So yeah, I totally agree.
So there's a couple questions. We're almost out of time, so maybe quick shot answers. There's 2 questions, one in the Q&A, one in the chat about restaging. So what's your restaging plan, whether it's imaging, selective versus routine, invasive, et cetera?
So we have this discussion a lot in our tumor board. You know, we restage them with CT and PET, but really to look for mets, not to look for anything else. I mean, I don't think there's any role for invasive restaging. And you know, I think if you look at the waterfall plots from all the IO studies, clearly we don't have a way of assessing response, right? CT and PET are not useful in telling us if someone's going to have a path CR. And so I think you can easily get tricked if you try to use either of those things to assess treatment. I think we just want to make sure they don't have metastatic disease, they haven't progressed on treatment before you proceed to whatever the next stage of their treatment is. I don't know if anyone else feels differently, but I think I'm pretty aggressive here about not getting kind of caught up in restaging their mediastinum.
Yeah, I'd agree with Nate. We do the same thing, the same as we do for esophagus. We get a PET CT before surgery, realizing that about 5% of patients will progress during their neoadjuvant. And like Nate said, we're looking for METs or a new lymph node that wasn't positive before, but in a station that would make them non-operable, like an N3, like you said. So we will do restaging EBUS, EUS for a MET or for another node, but not to do the nodes that we already know that they were positive, because we're going to operate on them anyways. And so it's pretty academic. If you're not, meaning if you didn't sterilize the N2 or N1 and you believe then that patient is non-operable, then do it. You know, that I'm okay with that. I don't feel that way and I don't operate that way. But if you're not going to go ahead, then you should do it. If you're going to go ahead anyways, what's the difference and why give them the risk? You know, EBUS has its risks. We've all seen abscesses or, you know, pneumonia or whatever, hemoptysis. So I agree with Nate. We're looking for something new.
Dr. Gonzalez?
No, I don't have much to add, no, to what's already been said. They're certainly not coming back to me for EBUS, so I think my surgeons are following the same.
All right, well, we're coming up on the end of the hour. Thank you all again for all your insights and sharing your stories. I think we're all in this together to figure out how to implement this new treatment paradigm. And it's affecting how we stage our patients up front. So this has been really great. Thank you.
A sincere thank you to our panelists for your participation and insight, and to AstraZeneca for their support. Register today for the STS 59th annual meeting and plan to reconnect with your colleagues in cardiothoracic surgery in San Diego. The early bird registration deadline for lowest rates is next Thursday, October 13th. Learn more and register at sts.org/annual meeting. Join us for the next STS webinar on Tuesday, October 18th, as an expert panel discusses preclinical and clinical trials on prolonged organ storage and the clinical application of these findings. Details are available on sts.org. Thank you and good night.